Good evening to you, everyone. I'm Jessica Ralston. Welcome to Medical Mondays on this January 12th, 2015. We got a big popular show for you tonight. We're joined by Dr. Yelameli from the Nashville Pain Center. So big thanks to you for being here again. And a warning to you all, fair warning that when the doctor's here, the phone lines get really, really busy. So if you have a question about pain or pain management and you want to talk to the doctor, please get on the lines now. And that way we'll try to get everyone in by the end of the show. Last time I think we ran out of time and couldn't get everyone's calls in. So make your call now, 737+. And we're going to kick things off tonight talking about some of the myths and misconceptions of pain and pain management. So how do you want to start off?
Well, there are plenty.
Yes, a lot out there, right? What do you think is the biggest myth?
The biggest myth is that it's among the pain patients themselves.
Okay.
They seem to believe firmly that if they are on pain medications and they have real pain problems,
okay,
they are not the ones who are going to get addicted, and they are following all the rules of opioid management, opioid medications, just because there are others who are addicts, real addicts who are abusing drugs on the street. So it's not so. It's not so. Real pain patients who are genuine patients who have real pain, chronic pain, if they are on narcotics for a long time, even for a short time, even they can start showing signs of addiction during the treatment. It is just, we should just consider that this is one of the adverse effects of a medication. Like if you're on blood pressure medication, you can have severe hypotension, that means decrease in blood pressure, and feel dizzy and have a complication from it. Similarly, narcotics or opioid drugs also have their own set of complications, and one of them, which is the most important, is addiction, and that can happen to anybody, even if a patient has a real pathology in the spine or somewhere else and is taking the medication for a genuine cause.
Right.
He can also get addicted, and if they keep thinking that I have real pain and I'm not going to get addicted, then that is going to cause more problems.
Absolutely.
In future, that they may actually really get addicted, and they keep staying in a state of denial.
Right, because in your head you think, hey, I have a legitimate pain, so I'm not addicted. I'm doing what I can to manage this pain.
So most of the time now, when pain specialists are treating these pain patients, we don't deal with real drug addicts. We don't deal with people who are intentionally abusing drugs.
Right.
We already know these people, and they don't even get in to the clinic, and they are on a different
right.
plane.
You can tell when people are coming in, they're doctor shopping for pills.
So we have already, these patients who come to us have already gone to other doctors, have had surgeries, have had real pathology already in their charts, already they have diagnoses that they are carrying, and we are trying to treat their pain. And if they can understand, the pain patients can understand that they can also, like anybody else with any other drug, can have a side effect or an adverse effect, they can also have this, that it will be very easy for us to manage their pain if they are aware of the fact that anytime they can also get addicted,
right,
then actually it decreases the chances of addiction.
So they're going to be more aware.
They're more aware of it.
Absolutely.
So that is one of the myths that I always try to talk to my patients and try to explain that, look, you are following the rules for your own good, not because you're protecting somebody, or if somebody else is addicted or something like that.
Right. Okay. Well, we already got some phone calls coming in, so we're going to go straight to Phyllis tonight. Hi, Phyllis. Thanks for giving us a call here on Medical Mondays. What's your question?
Yes, I'm a cancer survivor and a transplant survivor.
Oh.
And they said I had neuropathy in my toes, and now I'm having terrible pain in my arms.
So when you say arms, you mean fingers, hands, forearms, above the elbow, below the elbow, or is it just in the arm, in the elbow area?
No, it's up in my muscle area. Like if you make a fist and make a muscle, it's all up in there and upward toward my neck.
Towards the neck, okay. You don't have any neck pain?
Not really. Every now and then I feel like it's like poor posture or something like that.
So what kind of transplant have you had?
A stem cell.
Is it a kidney transplant? What organ was transplanted?
Repeat that again.
What kind of transplant have you had? Is it Is it heart, lung, kidney? I mean, there are so many different.
Well, I have leukemia.
Okay,
Right,
bone
and he's
marrow.
asking if you had if you had an organ transplanted, bone marrow.
Yeah, is it the
Bone marrow.
Okay, bone marrow transplant. So if you are a cancer survivor and you have had some chemotherapy, have you had any chemotherapy?
Yes, I have.
Okay, so when was that? Or how many years ago?
My transplant was done in 2012.
Okay, and when was the chemotherapy done?
2013, I'm sorry.
Okay, so recently you have undergone chemotherapy too for this cancer, right?
Correct.
Yes, chemotherapy, one of the adverse effects of chemotherapy is neuropathy. It can damage the nerves depending on what kind of drugs they used for your chemotherapy. Some of these chemotherapeutic agents specifically cause nerve damage, and you might have suffered neuropathy from that. Have you seen any specialists for this, neurologists or pain specialists?
No.
I think first thing to do is to talk to your primary medical doctor or to your oncologist who has treated your cancer and tell him about these pains, and they are aware of these things and they know how to treat this in the initial stages. Neuropathy can be treated easily by certain medications that we use for neuropathy. And if
I'm currently taking a medication.
okay, so if that is not helping you, then we may have to adjust the dosage of these medications. We may have to change the medication to a different one that helps you better. And those things can be done by a pain specialist or a neurologist. So you may have to get yourself referred to a neurologist if your pain is not under control, or you can go to a pain specialist too. And we are also well versed with these medications, and we can understand this kind of condition. And we may have to actually put you through a test called nerve conduction study and see if there is a neuropathy and what kind of neuropathy it is, whether it is really neuropathy or whether it is coming from the neck, or we can diagnose you better after these tests and then properly treat you for that.
Is that painful?
Yeah, the test can be a little painful, yes, but we can see. I mean, not always, not always.
I mean, because I already feel like my body's in shock because I've been having to have all kind of tests
Right.
to make sure that my body.
Yes, many times neuropathy can be diagnosed clinically without having to go through any tests. But sometimes if you are unable to say what kind of neuropathy it is, where it is coming from, then we may order a test for that, the nerve conduction study. So that is a better way to go. I mean, it's just a few, one-day test, and it's.
What type test is that? Because I know it's one test where they take pins on.
Yes,
So
that's
to stick you.
right. Have you undergone that?
I have.
And does it show neuropathy?
Well, that was before my cancer diagnosis.
Right. Yeah. So the similar tests will be done for you all again, to see what kind of condition you have.
Okay.
And then
Yeah, it sounds like she does not want to go through that
I
testing
mean, you don't
again.
have to. I mean, first you have to see the doctors and then see what they are going to offer. Then you can discuss it. It's not like we're going to push you into something which you don't want to do. If it's left to you, if you don't want to do the studies, then still we can treat you for the pain based on our clinical evaluation.
Okay. Well, I do thank you so much for your
You're
time.
welcome. You're
Right.
welcome. Thanks for calling.
Thank you. All right, and we also have Ann calling in tonight with a question for you, Doctor. Hi, Ann. What's your question?
Oh, yes. I was wondering if a person is on pain medications like a narcotic, should they take ibuprofen or either naproxen for their pain?
If you're what we do in chronic pain management is we do use non-steroidal anti-inflammatory drugs, but not on a regular basis. Because if you take
And where
those,
is your office located?
it's in Brentwood, Tennessee.
And we'll make sure at the end of the show, Ann, we give out the doctor's location, the address, email, phone number, and everything so you can get in contact with them, and the website too, okay?
Yes, thank you. And coming back to the question, we do use non-steroidal anti-inflammatory drugs, but at the same time, it's not on a regular basis. We use it for just arthritic pain. We will see where your pain is coming from, and if it is more arthritic in nature, we may add a non-steroidal anti-inflammatory drug once in a while. I mean, normally you take it for a week or 2 weeks and then stop it. You take it on a full stomach. You take it with some antacids or some medications that we use to prevent ulcers. And then again, you don't stay on it forever. and it's only in short courses that you use it. And sometimes we use topical non-steroidals, like there are several ointments and creams that are available that contain these medications like ibuprofen in various different concentrations, and depending on where your pain is, we may use that has slightly lesser chances of causing these kidney problems and ulcer problems. So we do use this, but very judiciously during the course of the treatment, because chronic pain is something that you have for years and years, and if you take these medications in high doses for years and years, then there are very good chances that it may affect the kidneys and can also cause ulcers in the stomach.
Okay. Well, I hope that answered your question for you, Ann. Thanks for calling in, and thanks to Phyllis, too. And if you have questions for the doctor, give us a call at 737+. When we come back, we have more questions and calls to take, and we're going to talk more about the myths and misconceptions of pain and pain management. So keep it here.